like auto accidents with like whiplash. What are usually the main injuries that we see in those, and then also like how we treat them, and what's the best treatment for them. And then we're also going to kind of go, Kristen's going to talk a little bit about just overall, like a lot of times what the benefits are for like insurance companies, like your auto insurance. A lot of people don't know what the PIP is. The PIP is something that every policy in the state of Utah has that helps cover like medical expenses, x-rays, if you have to go to the hospital, at least for the first little bit of money with that one. So we'll talk a little bit about that. Again, as in most brain talks, just because I talk about this doesn't mean this is the only thing we can talk about. If there's any questions about anything else that's in your mind or anything else that pops in, let's talk about it. Again, the clinic, what we do is we see a majority of like musculoskeletal issues, but we also see a fair amount of neurological issues, whether it be concussions, chronic migraines that have never been helped by anything else, emotional issues, behavioral disorders, those types of things. So just because tonight's brain talk is specifically on that doesn't mean that's the only thing we can talk about. So first thing I'm going to talk about is a little bit kind of on the biomechanics of a whiplash. And so this little graph that I drew here was actually like the, it was a study that was done in 1950, so it's a little dated, but they don't do a lot of whiplash injury or studies anymore because it's not ethical to do it on humans because they could get injured being in car crashes all the time. So this is from the 1950s, but what they found is this y-axis is the amount of G's that was generated in the car, in your torso, and then in your head. And this was the amount of time that it took to create those G's. And so all the G is just the force of gravity, which is 9.8 milliseconds or meters per second squared. And so 2 G's is just 2 times that, and so forth and so forth. So what they did is this car was actually stationary and was hit by a car going 8 miles per hour. So really not a big injury, or not a big accident at all. But the car in 300 milliseconds had a force of 2 G's registered in it. The torso, the person in the front, in the driver's seat, had their seatbelt on. Their torso, when they got hit, caused 2 to 3 G's when it started moving backwards, and then as the car went forward and their body kind of caught up to it, it went back down to about 1.5 to 2, and then they came forward even further and generated up to 4 G's in their torso. And then of course in the head, we can see it starts a little bit later because you can get that whip, and the head starts going backwards, and then it ends up being at 5 G's, so 5 times the force of gravity in just a 8 mile per hour collision. Okay? So the reason I bring it up is because 5 G's in the neck can cause a lot of damage to the structures, to the ligaments, muscles, and all that type of stuff, and that's just at 8 miles. Most car accidents don't happen at 8 miles an hour. They're not in a parking lot. They're out on Washington or on 12th Street or on I-15, and they're much more intense.
What about a force of an airbag? I mean, like
that on top of it, I mean, that ends up being a second reaction on top of it. So you might get the 5 from just even falling this way, and then the airbag punches you in the face, and then you have another one going backwards. So it's like a double collision on top of it. So it's just a good little kind of eye-opener of like, oh my goodness, like 8 miles an hour causes this. What does 30? What does a 40? Or hopefully never, but what is an accident on the freeway like at 50 or 60 going? And why we should always end up wearing our seatbelts. So the other things that we look at with this one is the actual injuries that are happening. So the most common one, and it's in layman terms, is a whiplash. In legal and medical, we call it a cervical acceleration deceleration injury, and that one usually happens from a rear end accident. Okay, pretty self-explanatory. You just fall forward and then bring it back, and you end up damaging the posterior elements more so than the anterior. But we see some disc injuries. We see a lot of ligamentous strains, muscle sprains as well. with those ones. When we see a lot of like lower back injuries, it's from our T-bones. So our low back injuries are more from being like T-boned or like being sideswiped. And the reason that is the way it is when we're driving, our pelvis is stuck in place by the car, or excuse me, by the seatbelt, but then the rest of our torso starts to bend and twist. And so this is stuck, and all the force ends up going into the lumbar spine. So those are usually the main two. On top of it, we do see a lot of brain injuries. We see like contusion, so bruises on the brain. We can see deep axonal injuries, possibly changing pathways in different lobes of the brain. So there can be a lot of that. We talked about the neck with the whiplash. Another main one that most people don't really recognize so much at the beginning is the jaw. If we are turned at all, any degree off of center, or leaning with a head tilt one way or the other, we will actually hurt the jaw. And with the disc actually in the jawbone. So that's a big one that we usually see. And this jaw gives the majority of its input into the brain. So it actually will accentuate any type of brain injury that we also have, whether it be a concussion, migraines, and things like that coming afterwards. So definitely got to make sure we take care of the jaw. The other ones that we see a lot of are upper extremity. So I just write it as a UE or a lower extremity. And that's looking at the brachial plexus and the lumbar plexus. And what those are nerves. This was the best way to draw it. I'm not a great artist, so bear with me on this one. Kristen saw what it looked like the other day. And she's already laughing. It's a great picture. So here's your head.
It's better than my artwork.
Okay, and we come down here, and we have our arms, thumb, index finger, middle, ring, pinky, and come back up. So, out of our neck, let's see, we have our top bone, 1, 2, 3, 4, 5, 6, 7. Obviously your neck's not that long, but again, not a great artist, so bear with me. But what we're looking at is this brachial plexus right here, are the nerves that come out of the neck that go into the upper extremity. So if you ever have like numbness or tingling in the arms, like you get that kind of dead, like your arm feels asleep, the majority of the time with that carpal tunnel, what a lot of people think of, is we get these nerves that are coming out of the neck that with the whiplash have been injured or damaged, and so now the nerves going down into the neck, or excuse me, down into the hand and the arm aren't doing very well. You get that numbness, that tingling, that burning sensation. Same thing happens in the lumbar spine. If we draw a leg, we have L1, 2, 3, 4, 5, and then it goes into the sacrum, S1, and so forth. These nerves as well come down and go into the different parts of the leg. So if we get T-boned and have that low back injury, we can have numbness and tingling down into the toes, down into the feet, getting to the point where you can't even pick up your foot and you can have like a foot drop. That usually is a sign of an L4, L5 disc that has been herniated pretty badly and might even need surgery more than anything else. So those are the main things we're looking at when we get an auto accident in here. So, when I have a patient that comes in, I go through sort of a grading scale with them through testing and so forth, especially with the whiplash when we're looking at the neck. And there's a grading scale. So it's the CAD, so the cervical acceleration, deceleration. We have grades 1, 2, 3, 4, and 5. 5 being a super severe one where they actually have a cervical spine injury, usually being like a broken neck, something like that, where they got to go straight to the hospital. Okay? But a cervical acceleration grade 1, they have minimal issues. They don't really have any decreased range of motion, meaning they can move their head fully and not have any issues, no real pain. It's just overall they might have stiffness and pain just in general, but not anything extra with movement. Number 2, they have cervical range of motion issues. So when they turn it to the right, they don't go as far as they can to the left, or it causes a lot of pain, or it causes neurological findings, or not neurological findings, but a little bit of pain that might send down. On number 3, they have cervical range of motion findings again, and they also have on x-rays like alignment issues. Nothing that's broken, they don't have like a broken neck, but they have super hyperextension or flexion misreadings on the x-rays. So we have x-ray findings. Number 3, again, they have the cervical range of motion, they have the x-ray findings, but along with this one, they have some fractures. And the reason that these are important is being able to grade them is because throughout all of the medical literature and throughout all of the different organizations and with the majority of insurance companies, is they've figured out like the protocols, at least the amount of visits and how long it should usually take. So that's why it's always really hard, and it's not just doctors being like, oh, I want you to come in because it's paying and whatnot, but this is what the research has shown to be the exact amount of visits and whatnot that you should have to make sure that the injuries are actually taken care of. So that's why it's super important to follow the care plans that are given. So I'll show you a little bit what they are. They're not too crazy, except for down here. These ones end up taking over years to do. This one you actually really don't see that often, because the majority of the time they just have a fusion and they just kind of deal with it. But people with this grade 1, the majority of the time, they see about 21 visits, and it takes about 11 weeks. Number 2, these ones are a little bit more. Again, they're seeing 33 visits, and it takes about 29 weeks. Okay? Number 3, we're getting up into 76 visits, and that's taking upwards of over a year at 56 weeks. Number 4, they have 107 visits, and they don't really have like a timetable. They don't really have weeks. Okay, and then the last one again is kind of seeing how they do after the spinal injury. So the reason I bring these up is, again, this is what the research has shown. And again, you don't have to go 21 visits. You might be okay after like 11 or 12. But we at least know it could take upwards of 21 visits to make sure that this neck is responding the way it's supposed to after the adjustments, after the stretches, after the exercises and things like that. So that's why it's super important to make sure that we actually understand, like, hey, this, yes, it's just a little whiplash, and we might not have too many big things, but if we don't take care of it all the way, it could lead to further injuries down the road. So that's kind of my spiel on the injury side of it. Any questions so far about any of those or about anything else that's kind of popped into your head?
What vertebrae down, and then you've got paralyzation in your neck, is that number 6?
So the majority of the time, it kind of depends, but C1, if that one's broken, that's that first bone right on the top of the neck, you will more often than not see a little bit of motor issues afterwards. C5 and 6 do go straight to the arms, and so they can have a little bit more, but the main things that we're seeing are when we look at a spinal cord, oops. When we're looking at a spinal cord, so this is the actual spinal cord. Up here at the top, we have sensory tracts that go up into the brain. So we have your legs and the lower extremities, and then you have the upper extremities next to it. And then down here in the anterior cord, you have a bunch of tracts down here. And they're just a bunch of nerve fibers that go up and down. So when a signal comes from the brain and it comes down, it'll leave or decussate and then cross out into the spine and travel down that cord to the level where it needs to go out and say to move my fingers. Okay? And that one might be at C5, C6, things like that. So if we ever see paralyzed patients or things like that, It's depending on where it is in the spine, just depends on where it hits, but it has to hit those tracks in the spinal cord. So a lot of times they're anterior discs, they're like kind of a big compression fracture that actually is like a burst type of fracture where the bone just kind of blows up in there, and it'll mess up with these tracks, these spinothalamic tracks and the corticospinal tract. That's usually the main one. And again, it can be both sides, going to both sides, so you could have both arms gone. It could be one side, meaning arm and leg, it's hitting the tract up here and going downwards. But the majority of the time it's usually C1, but honestly it could be any of them. It just kind of depends on how the fracture actually happens in the break in the spine. And then it'd be the same thing down in the lumbar spine. Again, L1 or L4, 5, and 6, or excuse me, L4, 3, 4, and 5 make up the majority of the muscles going down into the leg, at least down into the lower leg. The upper leg also has L1 and 2. So again, it kind of just depends on what type of fracture and where it happens to be at.
What about dizziness? I mean, cause like when your neck certain ways,
Get a little dizzy on that one. So with these, what I look at is when I look at the brain. So again, wonderful little drawing. So that's your face, that's the head, that's the brain that we think of, the pink mushy part. Then we have the brainstem down here. The brainstem is the part of the brain that we don't really think about. It pumps the blood, it does everything that's supposed to, it's automatic. What we're looking for is cranial nerve number 8. That's the vestibular cochlear. So the vestibular is the balance issue, cochlear is being able to hear. So a lot of times there could be an issue with that, where it doesn't integrate well into the brain and send a proper signal, and so people end up getting dizzy. The other thing we could look at is the cerebellum, which is the part back here, which does muscle coordination, and again, it does a lot of balancing issues with us. And the other thing that I specifically look at, like again, if we draw the face, I look at the eye, the ear, and the neck. There are reflexes that go through all of them. You have a reflex from the ear, or from the eye to the ear, which is the vestibular ocular, so it's a VOR reflex. You have the ear to the neck, which is the vestibular colic reflex, colic being the neck, and then you have an ocular colic reflex, which is the eye to the neck. So all of these work in unison together, and the best example I have for that is if you hold out a target and you stare at it and you focus on that target, then you turn your head to the left, your eyes will move inside the orbits to maintain the focus. So it's using the inner ear as we turn to the left, it's using the muscles of the neck to actually turn, but then it's also using the eyes. So all three of those systems have to be working correctly. So if we have an issue with our eye movements, we can have dizziness, we can have neck pain, we can have a whole host of things. Same thing with the ear. If the inner ear is not working well, we can have eye issues, not being able to focus well, getting dizzy, double vision, feeling like things are shaking, and then also neck pain. And then the same thing here, if we have the neck that maybe has bones out of place, and so it hurts to move our head, so we try not to move it, then we lose the reflex that goes up into the ear to tell us where we are in space, and then vice versa with the eye movements. So we have to double check, at least I double check each one of these systems by themselves to see, is it the eye that's causing the issue? Is it the ear that's causing the issue? Or is it the neck that's causing the issue? Or is it that cranial nerve number 8 that also runs through that ear with them? So it's kind of looking, it really depends on what the testing finds. But a lot of it can be changed just by rehabbing eye movements or rehabbing our vestibular issues with where we are in space and where we think we are versus where we actually are. Any other questions?
About anything?
I mean, before we get too crazy, I think I'll pass it over to Kristen because she does have some stuff to talk about, again, with more of like the injury or the auto stuff. And then we can get back into the brain things and kind of look at some other stuff on top of it. But yeah, the big thing is I just want people to understand, like, even though we might have a grade 1 where our neck's just stiff, we should still seek care to make sure that stuff doesn't turn out to be more. Because if we have a stiff neck, it could turn into dizziness, it can turn into eye issues, which then affect the entire brain. So that's just kind of why I wanted to talk about this one in a kind of different format. We haven't really talked about a physical one yet. Most of them have been like specifically brain-based, like anxieties or crazy major headaches, but they're all brain-based type of issues. Today I want to talk a little bit more about, hey, just a straight-up musculoskeletal issue can be causing a bunch of brain-based type of findings and stuff like that.
So where does concussion fall in those grades? Because concussion is possible from a car accident as well, correct?
So I would say most people probably say it's here, but my little sister, her worst concussion happened on one like this. She was sitting at a 4-way stop. She was a couple cars back, and there was a couple cars behind her, and someone hit the last person, and they kind of did the dominoes, doom, doom, doom. She was sitting in the front seat with her backpack on, so bang, super smart. And so she's sitting like this, and she just goes like this. That was all the injury was. It didn't even like have a scratch on the bumper, like nothing. She's a competitive dancer. She was dizzy, headaches, and vomiting for a month straight. Just from that. And that's where I'm saying, like, you get that stiffness in the neck, it wouldn't even register as this, because she was fine. She could move her head. Just every time it did, it made her nauseous. But that's because when this got jacked up or messed up, it changed her inner ear, it changed her eye function, and then that at the end of the day took this section, the fight or flight, and threw it through the roof. And that was her major concussion. So, most people would probably say grade 2. I would think anywhere from a grade 1. I've seen people with concussions that have even just slipped on the ice like that. Never fallen, never did anything, but just that little whiplash sent their brainstem into a frenzy and couldn't recover. So, I guarantee anybody that's been in an accident, whether it's just a 5-mile-an-hour fender bender out in the parking lot, has had a concussion. And those are things that need to